That's good. Okay, well, on that, should we get started? Start talking
Yes,
about all the things?
let's
Okay.
do it.
So this is kind of a different take for us in this little session. Y'all get me. I'm Melissa Witt. I usually am behind the scenes, so you may see my emails, but you probably never see my face. And that's usually intentional. So I'm a little outside the comfort zone here, but I actually wanted to jump in here with Andrea as a patient because I actually had no idea really about any of this stuff until about, I don't know, a year and a half ago. Mostly because Intimate Rose was like, yeah, we want to do this, go learn about it. And I was like, okay. And so I didn't know anything. And just from that perspective and kind of knowing that a lot of people are in the same shoes I was in just a year and a half ago, I think it's really important to continue having these sessions where people can feel empowered and educated and know their options, and know, the questions to ask, I think, more than anything. So, um, Andrea, do you want to introduce yourself and all your
Yeah, of
fantasticness?
course.
They may already know you.
I don't know, but hi, I'm Andrea. I'm a nurse practitioner. As we said, I'm on the East Coast, live in Philly. I work at a clinic in New Jersey, and I am a menopause expert. I love menopause. I love doing all the things. And just like you guys, probably used to not know much about it. Um, but I should have because I'm a medical provider. Used to provide horrendous menopause care, but I really become interested in it and learned so much, and I could talk about this all day long. So, Melissa, I'm really happy that you're here to be like, hey, you're getting nerdy. Focus.
We like nerdy. We all appreciate it so much. Um, okay, well, I think to kick us off, I think the first thing is just kind of defining for everybody again, kind of perimenopause and menopause. Because when I first started looking into this, again, because we were going to start offering this service, I honestly thought menopause was sort of like something I needed to worry about when I got closer to 50. I had no idea what its literal definition meant. And I really didn't know that at age 42, 43 at the time, I I could be affected by some of these symptoms. So can you just give us a little definition of the little stages that we should be
Yeah,
expecting?
I would love to. I know, surprise, surprise. Comes
Yay!
up when you least expect it. So I'll
Yes.
start with menopause. So the word menopause, it actually refers to one single day in your whole life. So it is the point in time where it has been 1 year since your last menstrual period. That means you're officially in menopause. The time leading up to that is called perimenopause, and that can be anywhere from 4 years to 10 years. It can last a long time.
Yay!
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 And it's those gradual changes that start to occur that lead up to menopause. And then I usually get asked, like, okay, when is menopause over? Well, menopause and then it's postmenopause. So
Right.
the rest of your life you're in what's considered postmenopause.
So just the rest of your life. So that's
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 all.
good. That's
It's like
good.
a 30-year life. So we need to make
Yes,
this a good time.
exactly. I was going to say the same thing. That I think that's what really kind of fires me up. Actually, now that the more I know about it, it's like you spend a significant amount of time. Like I was doing some content because that's my role, content one time, and it was like, um, the same time that you spend like raising your children, like that's going to be, and you're just sitting here like, wow, that's just a long time to not know anything about it.
Yeah.
So,
Yeah.
um, okay, cool. So when we're talking about perimenopause, that can start as early as, I know I was probably 41, 42. How early can it actually start when you might start to see those symptoms come up?
So when you look at the average age of menopause in the United States, it's 51.5, but it's actually a
Okay.
little earlier for Black women. It's usually like 49. Some Asian women can be a little bit earlier. So again, if we go by that metric of like normal perimenopause is anywhere from 4 to 10 years, 39 even can be like a normal
Okay.
time to start going through perimenopause. Again, not everybody's, having a 10-year experience. But most often it's like early 40s, sometimes late 30s when people start to experience perimenopause.
Okay. We just had a good question. So I think this is a good one. Does the definition change if you've had a hysterectomy but still have ovaries, fallopian tubes, and part of a cervix?
So it doesn't. definition only changes if your ovaries are removed because they're the ones pumping out the hormones. So if, say, you're age 42 and you have surgery and your ovaries are removed, that's called surgical menopause. So your menopause
Okay.
is that day.
That's the day. That's the party
That's the
day,
day.
everyone. That's the day. That's the day. Well, okay. So when I was starting to understand all of this, I was listening to a podcast actually. Dr. Mary Claire Haver, I believe, was on Mel Robbins' podcast. I encourage everybody to go listen to these podcasts. We can send links. She did this amazing visual. And one of the things she talked about was like menopause is one day. And I was like, oh my gosh, I had no idea. And then she started talking about like actually what happens. And she kind of compared some of it to like your cycle and then your cycle like never recovering. Can you give me a little bit of like a analogy to that? Because I think that really helped me sort of understand like, okay, this is what's happening and this is why it's happening.
Absolutely. I'm going to use my finger. My finger is going to draw
Yes.
in the air as if you can see this, but my little drawings. But basically, say you're a person with normal regular cycles, you have pretty predictable changes in estrogen. So, it's going to go up at certain times and then we expect it to go down at certain times and the whole cycle just continues over and over again. So again, there's some predictability there. When you get into perimenopause, especially early perimenopause, all bets are off. It is more like instead of a nice calm merry-go-round, it's more like a roller coaster where one minute you're up here, the next minute you're down here, and it's volatile, very volatile. And those extreme changes in estrogen are what really lead to a lot of these symptoms. And it's confusing because the beginning of perimenopause, you can have like symptoms of having too much estrogen at times, like breast tenderness, irritability, heavier bleeding. And then other times you've got the symptoms of low estrogen, like hot flashes, night sweats, vaginal dryness. As you get closer to that final menopause day, there's less volatility. It tends to just kind of decrease a little bit more. And then once you hit menopause, it kind of stays steady.
Okay. So that's awesome. That makes it really easy then in perimenopause to like know because everything's so consistent.
Yes. Yes.
Okay,
It's a
not at
bunch of
all.
very random symptoms at random times. So, as you can
Yes.
assume, very easy getting help for this.
Yes. So that's exactly what happened with me. I actually had my last kid like a month before I turned 40. I had Emmett and he, so I'm like 40 years old, starting to have like, trying to get back from having kids in my 30s. It was like my whole decade. It was like kids. I have four. So I was done, finished right before I was 40. But then, so I have the year, I'm nursing, hormone levels are kind of crazy, totally expecting all of that, and I'm like, oh, now I'm 40. So everything's just a little harder. It's why, and then like a year later, we start prepping to move. So now I'm going into this big move. We hadn't moved for 4 years, which was kind of weird for us as a military family. We move. So again, stress. I'm integrating not just, one or two people. Now I have these four kids. I'm trying to get them all. So a lot going on. Major change in our lifestyle too, based on where we were living in proximity to work and all these things. And I was sad too about moving. So I justified all of that for the longest time as to why I was feeling overwhelmed, a lot of anxiety, kind of mean. Like
Yeah.
now I know I was probably not the most fun person.
You're
And
not
just
alone though. I hear that from
right.
people all the time. And they're like, I feel so bad. Like I am snapping at my kids. I'm snapping at my partner and they didn't really deserve it. But like I know it's happening and I can't hold it in.
No, like that. I think you made a video like that one time, and it is kind of it was extreme, but it's actually kind of not because you really do feel a little out of control. That's how I always sum it up. Is like I kind of felt like I knew things weren't right, but I felt out of control. But I wrote it off as I'm busy, I'm tired, I'm stressed, and I'm sad. Um, and then I started reading about all this, and I'm like, perimenopause, you might feel inconsistent feelings of these things, and you're like, oh, what? So then that's when things started clicking. But tell me a little more about other symptoms, because I feel like in perimenopause, especially, probably what I was feeling is more common. I wasn't getting much of like the hot flashes and stuff, which I know you said tend to go later. But isn't there something crazy like 100 symptoms now that are like maybe associated to menopause?
There's so many. It's ridiculous. It's well, because
And
here's
weird
the
ones,
thing. Yeah, they're weird, but
Yeah.
it affects every body system. Like, and this is kind of the issues. Menopause, it's always like, oh, it's a ladies thing. So like maybe just your GYN should know about it, but even they don't know about it. It affects everything. So like starting, where shall we start? Your brain, mood changes. Estrogen has a big role in serotonin production. Progesterone, another hormone that we end up kind of losing out on, has a really big role in helping us sleep and helping kind of calm anxiety. So you've got worsening, anxiety, depression, mood swings. People notice dry skin, dry eyes, itchy ears. You can have
Yeah.
palpitations, bowel changes, again, the hot flashes, night sweats. Some people actually get cold sweats and like kind of shivery.
Yeah.
All the vaginal bladder symptoms like vaginal dryness, pain with sex, vaginal itching, urinary frequency, urgency. Lots of fun stuff, but again,
And
this is
things that you might experience for other reasons. So it's hard to
exactly,
always feel like, oh, yep, this is it.
exactly.
Okay.
Yeah, and I think some of the reason women get brushed off sometimes it's because it's like, okay, I have this random system from this body system and this over here and this over here. And then they're like, well, that's not related. But other times it is. It's all from the
Yeah.
same thing.
Well, and I think, that's exactly, I kind of got told in my wellness checkups, like the more recent one I'd had kind of in the midst of all of that moving and stuff. And it was just like, I mean, I was even like, I'm sure I'm just really over, I'm just stressed and I'm tired.
Yeah.
And all of that is making everything else harder, and yeah, my NP, I wish I had Andrea as my NP, but I did not. And she was like, yeah. And there was nothing. I mean, I never would have thought to be like looking into or asking more. I
Yeah.
didn't know to ask more questions or,
No.
so I look back on that and I'm like, wow, maybe I could have been nicer for a year. That would have been cool. Um,
Sure
okay.
would have
So
been nice.
then we know we have all of these things.
Mhm.
We may feel that HRT can help, and hopefully we maybe could talk to our provider about that. But I don't understand. So now we get to like where when in my journey, I was like, okay, hormone replacement therapy. Like honestly, I didn't even really understand what that meant. Like, are we talking like an infusion? Are you like going in and like what exactly is happening? Like, and then it ends up being like even a little more complicated because there's all these different ways that you can receive hormones. So let's talk first about HRT and why sometimes we also refer to it as MHT, and
Mhm.
then BHRT. I got to get all my acronyms. So let's define all that for everybody because I think that is something, and kind of start to give them insight into like what that is, like physically, like how does that work?
This is where I think it gets unnecessarily confusing, where we try to make things better and we make them worse. But the older term that we would say is hormone replacement therapy. At some point, it was decided that, maybe that's being a little dismissive. Like when menopause comes, we're not trying to like replace the levels that you used to have when you were 18. We're just trying to augment it a little bit. So then it changed to like menopause hormone therapy or MHT. You have people that will like argue back and forth about it, but and people are generally talking about the same thing. And then the BHT is referring to bioidentical hormone therapy.
Okay.
So that kind of refers to a more specific type of hormones that is offered.
Okay. Cool. Very clear.
Yes. Yes.
Okay. So then before we get into like all the nuanced stuff there, so by taking some sort of HRT, BRT,
I don't care what you
MHT,
call
whatever, the T's, the HTs,
it.
what does that do? Like, what are we doing by doing this? I mean, obviously we're replacing, but like how does that help?
So again, that really kind of depends on the body system and how it's
Okay.
bothering you. So taking like in consideration, let's say like hot flashes, night sweats. So estrogen maintains this like thermoregulatory zone of like, okay, the body can be within this couple of degrees and we're okay, we can handle that. When your estrogen decreases, the little zone goes a lot narrower. So you get out of that zone and it's like hot flash, I'm cold. It just becomes a
Right.
little nutso. Um,
Yeah.
Again, in our brain, for moods, things like that. Estrogen's helping to regulate serotonin, norepinephrine, and progesterone's helpful with kind of calming things down in our brain, helping us sleep. It's even like estrogen's actually very anti-inflammatory. It helps like neurons to grow and to communicate with each other in your brain. In
Oh,
your
nice.
I know, it's really nice. In your musculoskeletal system, it helps bone, it helps prevent loss of bone, it actually helps build bone. It even talks to these little cells called satellite cells in muscle that I always say they're like the little ambulances that come if you have like a tear or an injury to your muscle, like it helps them come and repair the muscle. So when we don't have enough of these hormones, obviously you start to have deficiencies or issues in these certain areas of your body. So then when you take it, it helps with all these things.
Yes.
Mhm.
Okay. Then, so if it seems like it's so helpful, why has there been all this fear? Like, I feel like the first thing I get, well, in my crew, in like the early 40s, and all my friends that I talk to at like baseball fields and soccer games and things, they honestly kind of blank over, like they glaze over, like they're like, oh, just like I would have a year and a half ago. I mean, there was really a lack of awareness, even I think, in our age group. Then if you talk to anyone a little bit older, they're like, oh no, nope. The only thing
Yep.
they know about it is that they're scared of it. And so
Yes.
why is that?
Yeah, absolutely. And this is a lot what you'll hear when you talk to maybe your mom or your grandmother. It'll be like an absolutely not. That stuff is bad for you. And I know exactly why they think that. Hormone therapy was very popular in the 90s. We were doing lots of studies. It was like, wow, look at all this great stuff that it can do. And then they launched this huge study in the government called the Women's Health Initiative. And for various reasons, it got halted early. They came out with this claim that like hormone therapy increases your risk of breast cancer. They literally called a press conference at the Watergate Hotel. Do you ever recall any other medical study, them like, oh, stop the presses. We got to talk about this. Every morning show was putting, it was everywhere. Hormone
Big deal.
therapy, bad, breast cancer, you're going to die, all the things. And then what happened? Everyone threw away their hormone therapy. They stopped teaching about it. Medical schools, nurse practitioner schools. It was just like bad, we don't do it. But what happened? There's multiple things that happened, but basically, some of this data was released early without appropriate statistical analysis. What we actually found was estrogen decreased risk of breast cancer. There was no nuance in how estrogen was administered, the type of estrogen, like all this stuff really, really matters. You can't just say like estrogen and then it applies to everything. There's tons of nuance. But that message is, nobody called a press conference at the Watergate Hotel to be like, oh, we may have misspoken. So what happens now, you've got an entire generation of medical providers who weren't taught this. So even if, you go and educate yourself and you show up at your doctor's office and you're like, I want to talk about this. And they might also be like, no, that's bad. So
that definitely happens. That definitely happens. Or they just don't go there, I think, more than anything, because they're probably not sure of themselves. So
yeah.
Well, that's good too. Okay. Full of good news here.
It keeps getting better.
It does. It does. Okay. So, but we know that it is safe, in the right conditions with the right medical history. I mean, obviously there are exceptions to all of that. And we know that many medical providers may be resistant to it because simply they just really are uneducated about it. They haven't been brought up to the latest modern research about it. Okay. Should we dive into like the nitty gritty?
Let's get into it. Let's get in there.
I think, and I'd love to hear from our friends here in the chat too, because I think one of the things that I want to put together is a more visual explanation of everything we just went through, because I think that it's so powerful when you kind of see like, here's what you were in, like in your 30s, this is what it kind of looks like. And then now here's your 40s. And then, here's this. And I think you did a good job. And if I could like put that into a quick little thing, and then you also see the different hormones, because we're about to talk about the hormones. And to me, you start putting all of that together and I just get a little, we're not as medically sound as you, Andrea. So we kind of lose, you know, with all
Melissa,
these.
I love a picture. I love a drawing.
Sure, get me a
You
picture.
see it and you're just like, yes,
Yes. But let
that's
me
what
know
I'm
if you guys
feeling.
think that would help y'all too, like if any of this, and even with just treatment options, I think the more visual we can be, the better. So,
I agree.
as we are saying that, let's get into kind of what do we need? So we identify that you may be a candidate. What do you need for this? Like, there's a few different hormones that might need to be replaced.
Mm-hmm.
How do we factor in
Yep.
all your things? Like, tell me all the good things here.
So the main hormone that gets all the attention is the estrogen. So that's our main gal. She's doing
Mm-hmm.
the majority of the legwork, you know, helping with joint and muscle pain, hot flashes, mood, all that kind of stuff. So the one thing that we have to take in consideration when we're giving somebody estrogen is, do they have a uterus or do they not have a uterus? Because
Okay.
the one thing that estrogen will do is it kind of tells the lining of the uterus to grow. That's fine if it's before menopause and you get a period every month. I almost said every year, every month. And the lining sheds and that extra buildup goes away, no big deal. After menopause, though, that would just keep building. And over time, if you just let it do its thing, it could increase your risk for uterine cancer. So
Okay.
to prevent that completely, we give you progesterone. So progesterone, our friend progesterone,
She's
stops.
my favorite.
She's lovely. She stops that uterine
When
lining
she's
from growing.
full. Yes,
Yes,
when she's happy.
exactly. But progesterone has other benefits. So again, it's really helpful for sleep, for mood. I think in coming years, we're going to see a lot more of what progesterone does, but probably hasn't been getting credit for. So maybe she'll be right up there with estrogen. I don't know. But that's kind of the main things when you think about progesterone. And then testosterone, that's, I always say, is kind of like the cherry on top. So our biggest thing, the thing that we have the most research for, is that testosterone can be really helpful for helping with libido or sex drive in postmenopausal women. We have smaller studies that show maybe help with mood, bone mass. We do have a pretty good amount of studies that show it helps prevent loss of muscle mass through menopause. But again, that's something that we really need a lot more research for. And I think over time, we're going to be like, whoa, look at what else it can do.
Yeah. Okay. I know testosterone. I have lots of questions around that, but we might have to do like a whole thing on that one one day. Um, okay. So those three things are kind
Mhm,
of the main things.
mhm.
How do we figure out how we take them, if we need them, which ones, what combination? I think we need to create little characters around these people, around the hormones.
Yes. Yes,
So it'd be easier.
absolutely.
But how do we figure out who plays nice together and how much and how to take it? Um, all those
Yeah,
things.
a lot of it comes down to personal preference, what symptoms you're having, where in this journey you are in medical history. So for instance, in general, when I'm looking at a patient who's like very early perimenopause, again, they're in the beginning of that volatile cycle, so they're going to have very high levels of estrogen at times. So I don't necessarily want to add more onto it. That's not a good time to necessarily add it yet. They probably need progesterone because that's what tends to fall off first. You're
Yes.
like, yes, I concur.
I
Um,
will tell y'all now. Yes. It
from
works. It
personal
works.
experience. And then as we progress, it becomes more like, oh, we need more estrogen support here. And then, you know, the testosterone again is more of the, at this point, you know, looking into sex drive, libido, that type of stuff. But we also dabble for other things. And, you know, if it seems like it might be a good fit, we add it on. Again, if you have a uterus, you have to take the progesterone with the estrogen. And then I know there's different formulations and, you know, all the things, lots of questions. So even like dose wise, people is like, how do you know which dose that's right for
Yeah.
you? I am more of a start on the lower side and we can always work our way up. Our goal is basically to get you to the dose where you feel the best. It's not super
Yes.
scientific. What feels
Nope.
good? All right, we stop there. That's it.
Yes. Perfect.
As far as like formulations, so estrogen can come in the form of a pill, a patch, a spray, a gel, a vaginal ring.
Yeah.
Um, this is really based on medical history and preference. So medical history meaning when you take estrogen by mouth, there's a little bit of, it's small, but there's an increased risk of developing a blood clot. So we're not going to give that. That's not our first choice for someone who's already at a higher risk. Maybe they have high blood pressure, or diabetes, or high cholesterol. We're going to give you some of the other options, which are called transdermal, which means you just absorb it through the skin. It didn't have to go through your liver first, which increases your risk of blood clot. So that's really our big determinant for, oral or transdermal. And after that, it's just, what do you prefer? Some people are like, I would love to wear a little patch on my skin. Others are like, I don't want a little sticker on my skin. I don't like Band-Aid residue. I don't want somebody to see it, or differences. And I would love to use a patch because it's only twice a week, whereas someone else would say, like, I'm never going to remember to do that. I need something that we do every day. So it's really up to preference.
Well, I've tried a couple different things, and I've ended up like you can try things too, and it doesn't mean that you're stuck in it forever. You can kind of see what works for you. Because I did change mine, and I'm happier with I do the gel, and then now I do oral progesterone because when I did the cream, I didn't one I wouldn't have known. I just happened to change my stuff up, and I realized that on that oral progesterone, I think I texted you, and I was like, girl, or is there like a legit thing to this? Because like is oral progesterone maybe a little more effective, but it sounds like maybe it could be a little more effective orally.
So I love this topic. So progesterone creams and wild yam creams and all this stuff are very popular and being sold a lot. But progesterone is a giant molecule. It's huge. It does not absorb well through our skin. So when you're using, like, a lot of places, like you said, sell progesterone cream, you're barely absorbing any if you put a cream on. So for one thing, it's not safe. If you need uterine protection, you have a uterus, you're postmenopausal, you're on estrogen, progesterone cream is not going to protect your uterus. You have to take a pill. The other thing is you're kind of paying for a cream that's not going to do a whole lot. Like, you may get a little bit of symptom improvement, but you need like a dinner plate amount. So picture my head basically of progesterone cream per day to really get the benefit that you might get from taking it by mouth.
Wow. I mean, I definitely experienced that personally. And I don't know if I ever would have known if I hadn't, just from a preference standpoint. But I do the gel for my transdermal option. And I do like that. Yes.
Yeah.
And you can
that absorbs very well. Progesterone, not so much.
It does. It absorbs great. It's pretty quick. I do it at night. I do mine at night, but you can change that up, I know. So well, in an Intimate Rose, I know we have several different estradiol, which we also should talk about, estrogen options basically, but we do have the patch, and we have oral, and we have the gel. So you can pick your favorite there. And then we do have oral progesterone. So yay for that. Okay. What about vaginal estrogen? So what's the difference with like localized estrogen versus what we just talked about, which is systemic, right?
Vaginal estrogen is my favorite. I am her ride or die. So basically, the other stuff we were just talking about is hormone therapy for your entire body. It's called systemic hormone therapy. Vaginal estrogen basically works where you put it only. So it's really only treating the vagina, the vulva, bladder symptoms, things like that. So again, this is where that nuance comes in. If we just say estrogen, there's huge differences in taking estrogen for your whole body versus estrogen just for your vagina. Vaginal estrogen is ridiculously safe. There's almost nobody we wouldn't feel safe giving it to. So it's just, that's in a whole other category by itself. And it's amazing.
Yes. And so you may theoretically be on an estradiol patch, progesterone, and vaginal estrogen. You could take all three of those at one time. Or you may be on any combination of that. But that is an option. That is something that happens, that you might be.
The one weird thing about systemic hormone therapy, and I don't know why, for some reason it just doesn't seem to reach the vagina unless you're on like much higher doses. For some people it will. So it's not uncommon for someone to also be on vaginal estrogen plus the whole body hormone therapy. It's not like you're doing too much or you're overdosing. You probably need it because it's not going to necessarily do anything anyway. So
right. Well, in vaginal estrogen, some of the specific things for that, like, so who would be a candidate maybe for vaginal estrogen versus just systemic alone? Like what type of things would you be looking for?
Yeah, so vaginal estrogen is going to be great for those symptoms of pain with sex, that itching, dryness. Like usually patients are like, oh, no, I'm suddenly aware of my vagina. I'm just like walking down the street and I'm like, I didn't used to think of it, but now I just feel it. Recurrent urinary tract infections is excellent at preventing those. Urinary urgency, frequency. And there's no age at which I would say it's inappropriate. You can't start too young or you can't be too old for it. Vaginal dryness can start even like 10 years or more before going through menopause.
Yes.
So,
Well, and for like things like breastfeeding and things like that, right? Like that can be a symptom.
yep. Yeah. Breastfeeding is almost in a way similar to menopause. You've got this huge drop in estrogen, so you can get menopause-y type symptoms when you're breastfeeding. Or same thing when you're on birth control, because birth control just kind of shuts down ovulation. You don't get any of those nice peaks in estrogen, and then over time you can get dryness and pain. So vaginal estrogen helps great with that.
Well, if I want to know for sure, would labs tell me like you're deficient in this and this? And that way I would have a better idea of like which formulation or which type of therapy I might need. Can I get that from a lab? Getting my labs done.
So this is kind of like the beauty and the downfall of menopause. You don't need labs. They're not really going to offer us much. We call like diagnosing menopause and, well, more so perimenopause, like a clinical diagnosis, meaning like I look at you, you tell me your story. I'm like, oh, shoe fits, you're in the right age range. There we go. But the issue with labs is that they're so variable. So we'll take this apart, looking at perimenopause. Again, all over the place. Estrogen high, estrogen low, estrogen high, estrogen low. It's not necessarily going to match up to the symptom that you're having that day. In fact, it can actually be very frustrating for patients because they're like, I just want to know. So I'm like, all right, let's test it. And then their estrogen comes back so high and they're like, well, why am I having hot flashes? I'm like, because tomorrow it will be in the toilet.
I didn't think about that part of it actually, that it could be like confusing and frustrating.
Like I know people want like that validation of like, see, that's why I feel this way. And sometimes you don't get it.
No.
Yeah. And then once you're menopausal and you haven't had a period for a year, I don't need labs. I know. I can tell you what your estrogen is. It's same thing with your progesterone. You're not ovulating. It's not happening.
Finally predictable. We know.
Yeah, I know. We know. So in a way, it's good because you don't have to go out of the way and spend money and get your blood drawn. But I know people like numbers, and I get that too. We like data.
Yeah. You don't necessarily have to have it. Treat the symptoms. And I guess the other thing that we've talked about before is just like you wouldn't prescribe it to someone who has any red flags before. Like that wouldn't be an option. You'd be looking out for any of the reasons why they shouldn't. But if you do prescribe it, there's really no harm. Like it's such a small thing that like it's not like you're taking a big risk if you are setting them up. Okay, let's try to help these symptoms. And maybe, you know, it's okay. And something we haven't talked about is the preventative stuff that HRT offers. So, you know, not only are you potentially relieving symptoms, but one of the big things that helped kind of get me to, hey, I want to try this, one, to be nice again. And then two, the preventative stuff, you know, like I had started to read all of these things that it can actually help you with later in life. And, you know, I already have all the pelvic health stuff beat into my head, like do all these things proactively. So now I'm like, okay, I need to do all these things.
Yeah.
So tell us more about all the benefits of being on it over and beyond just like returning to your best self.
Yeah, no, it does a lot of invisible work. To me, the biggest one, the hugest one is the bone health and preventing osteoporosis. So that is one of the FDA indications for giving hormone therapy is for if somebody has low bone mass. We really start to lose our bone mass like even 2 years before our last menstrual period, and then it just continues to decline. And women are at such a high risk of osteoporosis and hip fractures and, you know, issues with the spine. And it's one of those things that completely changes your life. I've known so many women that were independent and they're gardening and they have their house and they're enjoying retirement and all the things, and they break a hip and their life trajectory has completely changed. And how amazing is it to just prevent that in the first place. It's so, so good for your bones. And there's no glaring, like we call osteoporosis the silent disease. You don't really know you have it unless you're looking for it or until something happens and you break a bone. So to me, that's like just that alone.
Right.
I could just protect all the bones. Again, with we have some really good data that especially when hormone therapy is started closer to the time of menopause or the last period, that it's good for the heart. Do we have official guidelines that say, you know, start this to prevent heart disease? No, we don't have that. I don't know if we'll ever get that. But we certainly have a lot of data that it can decrease cholesterol. It can help with like the elasticity of the blood vessels. It's just really good for the cardiovascular system. I know people always want to know about brain health. And this is where I think we have like the least amount of information, but we're getting more and it's very exciting. We know that estrogen is so good for our brains. We know it. Do we know exactly, like if we replace it, does that, you know, decrease rates of dementia, things like that? We don't really know that yet. And they're studying that. So hopefully soon we'll have more.
It has to help because
I know.
To me, even indirectly, like,
I know.
let's just look at that. You know, it's like, okay, so you replace estrogen and it helps you sleep and think and eat better and feel in control and all of these things. And, you know, it's like,
I know.
it has to help. It has to help.
The one area where we know for sure it actually helps with cognitive decline is women who are diagnosed with premature ovarian failure, meaning they're basically going through menopause very early, like before age 40. We have studies on them that if they get their estrogen, it helps prevent cognitive decline. So we just need studies to get the older group.
Need more studies. We need more studies.
Yes.
Okay. So now that we're talking about preventative benefits, we've talked about also when to start. And we know that that can be as early as maybe late 30s, you know, might be a time to start. When is it too late? I know you get this question a lot, but when is it too late? And then on top of that, like at that point, you know, are you still reaping any of the preventative benefits, you know?
Yeah, it's a good question. And I really feel for people who, especially were going through menopause or perimenopause around that 2002 area, because all those people were just basically denied hormone therapy. And now they're learning about it and like, hey, I want in. So as far as cardiac health goes, we know that the major benefits are within those first 10 years of menopause, even more so in the first 5 years of the last menstrual period. There's no data that after that it's going to do anything beneficial for the cardiac system. You know, brain health, we're not like before, we're not there yet. So bones are a different story, and this is where it really takes a nuanced approach, and you really have to get in there and discuss with a professional. So there's good data that, again, it prevents the progression to osteoporosis. There's actually very good data that it can treat osteoporosis. People might not like me saying that they use it in Australia to treat osteoporosis, but not in the United States. We have the same bones and the same medicine and good data, whatever. So there's no difference in our bones versus theirs. So again, looking at like a very healthy 70-year-old and say they have osteopenia and say they've got a lot of other, you know, very healthy people, to me, not unreasonable to have that conversation. That bone health, that bone build back, you're not going to see really a difference in bone density for about 6 to 12 months of being on hormone replacement therapy. And then to have like meaningful changes where now we know it's decreasing your risk of fracture, it might take another 2 years. So it really depends on the individual, their health, all that kind of stuff. But the one thing I will say, vaginal estrogen, never too late to start. In fact, the older you are, the more I'm like, you need this now, because those changes that can happen with the vagina bladder get worse over time. And that is like a never too late to start, never basically unsafe thing to start. I don't care how old you are. I don't care if you're 120, I will give you the vaginal estrogen.
There's an easy tool in your toolkit, y'all. To have
Yes.
the whole time. All right. Trying to think of like where to go next here. We have all these questions. I know I've had some people say, I submitted a question. We did get them and we're trying to like make sure we get to as many as we can. Andrew, you might have to talk to me again. We might have to do this like a round two.
Let's do it.
Yes. Okay. What about if I'm on birth control and I'm in my 40s and 50s? What do I do? Do I have to stop it? Can I do this? Like, what's the deal with if you're on you have an IUD maybe, or birth control? Tell me
So
the things.
number one thing is, can you get pregnant? Do you want to get pregnant? Is, if your partner is male and had a vasectomy, like, okay, none of this matters. So important to know, hormone therapy is not going to prevent pregnancy. So if preventing pregnancy is your number one goal, you stay on that birth control.
Prioritize.
Yes. So as far as knowing when you're in menopause on a birth control pill, we don't really know. You don't know unless you stop it and kind of give it a few months and see what happens. But also some people, what will happen is they'll get breakthrough symptoms, like they'll start to get hot flashes and stuff like that. And we're like, oh, time to switch over. We generally don't recommend staying on birth control pills after the age of 55. So at that age, you're kind of cut off anyway. We'll automatically switch you over. IUDs are a different story. I'm like, don't get rid of it. Keep that baby in because it's excellent at protecting the uterus. So if you want to add in your estrogen therapy, you're already good to go. So there's no way to like really, really know on birth control unless you stop. But you also don't need to know. You can just go by your symptoms, your risk factors, things like that.
That's right. Treat the symptoms and reap the benefits of all the things.
Yes.
What about, I kind of skipped this question, so I'm going backwards, but when should you stop? So I know we talked about like if you're eligible, but like how long am I on this? Tell me now. How long am I going to be doing this? Am I on it forever? Obviously, that'll probably change like my dosing, what I'm on as I move through, but how long am I doing this for?
You're doing it as long as you want to. Or
Okay.
if you then develop some kind of health condition that now we're like, oh, maybe it's not such a good fit.
Okay.
It used to be, we always used to be like, oh, use it for no more than 5 years, and we have to stop lowest dose as soon as possible. And we have since reversed course. We're like, maybe we were being a little bit too cautious. My thing is always, all right, at what age would you like to stop getting the benefits? So at what age would you like to have, lose your bone mass?
Right.
To me, I'm not going to stop that. But again,
Yeah, and I don't know how you would know. Like, how would you know if like I'm good now? Like, I mean, the preventative benefits, you don't want to let go of those, but it's also like, I don't know, maybe I'm nicer without it still now because everything's more even, but I don't
might
really
be.
know. I might
You
be,
might.
but so there's a chance that I would stay even on systemic through my, okay.
Yeah,
Okay. And
absolutely.
that's okay. There's no like risk at that point at all, really. So
No. Stick it out.
that's an easy answer.
Yeah.
All right. What about will HRT stop your period? So if I were to start this, there's no chance of that.
No, they're pre-programmed. They're gonna stop when they're ready to stop.
Yeah.
They don't care what the HRT is there for. Again, like birth control overrides the whole system, like ovulation, everything shut down.
Okay.
Hormone therapy is much teenier, tinier doses. We're just augmenting, and whatever's still gonna happen, happens. So that's again why it doesn't work as a contraceptive, because it's not shutting everything down. It's just little bits.
Little bits. I actually think that was probably my biggest symptom with when I kind of was going through all these weird things. My period was just like bananas, and I had never had problems there. I was fortunate and just never was very regular. It's fairly predictable. If I had any fluctuations, it was obvious why. Like we had been on vacation, or I mean, you could always kind of point to stuff, but then all of a sudden, like I had longer periods and like things were really a little bit more unpredictable, and my menstrual symptoms like beforehand were not great. Like it was, and then it really did feel like half my month was like kind of around what was going on, where it was never like that. And then, had read a little bit about that. All the other things too were factoring in, get on HRT. And literally within like that first month, my cycle came and was completely normal. She was so happy. So I just think that's so bizarre, that like, I don't know, it just needed a little bit of like, it needed help scheduling.
Yeah, no, it did. And we see, people that have a history of PMS or PMDD, like those major mood changes with their cycle, perimenopause tends to be a bit more rough for them because it's almost like an extended PMS type of thing. So in those cases, yeah, the mood swings can be really, really severe and absolutely need some help there.
Awesome. We had a good question, and we've kind of touched on it a little bit, but just to hit on it kind of directly, can HRT be based on physiological needs instead of just symptoms? So I think she's thinking more like physical, right? Like, or what is she meaning exactly?
I was assuming she meant more on like the prevention type stuff, is my guess.
Okay.
But if you're
Okay.
here and we're wrong, please feel free to tell us. So,
Probably
so
right.
yes, and this is kind of where sometimes you'll run into like a little bit of like headbutting with somebody prescribing, or they'll be like, "Well, you don't have symptoms." Well, if you have low bone density, like there you go, you're good, you're in the clear, easy peasy. And the only way to really test that is to get a bone scan. But if you have like high risk for that stuff, maybe you had like your mother had osteoporosis, she broke a hip, something like that. I would absolutely start somebody on hormone therapy based on, again, kind of those physiological needs.
Yeah. Okay. Um, I want to get to this one because I know we have people that have asked this. We talk a little bit about HRT when you have the BRCA genetics, the gene. So you know that you have that. Is this still an option for you? What does that mean? What does that look like?
Yeah, so the BRCA gene or the BRCA gene is basically a gene that means that you're at a higher risk of certain cancers, including breast cancer. And breast cancer is usually one of those things where we're like, maybe if you've had breast cancer, you're probably maybe not such a good candidate for systemic hormone therapy. But with the BRCA gene, you're at risk for it. You have not had cancer. So we actually very much recommend hormone therapy in this group, especially because one of the recommended things is getting your ovaries removed. A lot of these patients end up getting their ovaries removed pretty young, like after they're done having kids, maybe in their late 30s, early 40s.
Right.
The earlier you go through menopause, the higher the risk of having heart disease, cognitive issues, things like that, bone loss. So it's actually written like the Menopause Society, which are usually pretty conservative people, but they made a statement in 2016. They're like, no, we absolutely recommend this for people who've had the BRCA gene, even if you haven't had a prophylactic mastectomy. So yes, not a contraindication.
Perfect. So Intimate Rose, we currently don't take that. We have to rule that one out for now, but we're really hoping to expand on that because we truly believe that as well. And it's just some limitations for us, but we really hope we can do that because we agree. We're really excited that it's not, restricted for them.
We're working on it.
Yes, we're working on it. One more thing specific to HRT. Will HRT help with weight gain or contribute to it? And I have my like anecdotal advice or like insight here, but go ahead.
I love this question so much. There's no evidence that it will worsen. It's not going to make you gain more weight. Occasionally, some people will get bloating when they first start it, and sometimes it will last up to 3 months, and that's strictly water weight, and then it goes away. It's not going to make you gain weight. Now, is it a weight loss medication? No. In and of itself, does it make you lose weight? No. However, I always say that it puts you in a position to now make weight loss more possible. For instance, if you're not sleeping well, who's going to get up and exercise and create a healthy meal when they're running on 3 hours of sleep? Not I.
Yes.
Exactly. If you don't feel good and you're having all these mood changes and all that, again, who has the energy for that stuff? There's also some evidence that it helps with like glucose metabolism and insulin sensitivity and all these things. So it sets you up for success.
Sets you up for success. I personally, I didn't lose a lot of weight, but I felt so much more in control. Like I stopped gaining weight, I guess is where I should say. It's like I really did like, but I think that was all, you go back and you're like, I was so tired. And we all know that when you're tired, you tend to like not eat as well. And then, you're like stressed and you're anxious. And I'm a big comfort food girl, and so it's like all those things. when I didn't feel so overwhelmed and I was sleeping, because progesterone is now my favorite person. It's like amazing. And so all of those things got better. I also I did go on a probiotic like right away because I did feel like kind of bloated pretty quickly. I think it subsides though. Like, you said, I think it like goes away pretty quickly, but I just started on a probiotic
Yep.
and that's been a big help. So
And one of the things, I think it always helps to know how these things work. So with estrogen, by nature, it's kind of hydrating. It helps you hold on to water in your cells. So sometimes when
yeah.
you are bloated at first, it means that you're actually very dehydrated, and the estrogen's like,
Yes.
hey, let's hold on to some
Yes.
of this. Progesterone can actually be a little bit of a diuretic and help you, shed some of that water if you have that. But again, it's kind of a good thing if you do have a little bit of that water retention. It's meaning you're getting some hydration to your cells.
Yes. Good. Well, yeah, it's been good for me. I definitely don't think it added. It helped like just stabilize and everything else. Okay, we had a few questions in the chat. I know we're getting close on time, so I wanted to kind of pivot over here. What are the bladder problems that are helped with vaginal estrogen? And does it help vaginismus? Because this is, as you know, very close to a lot of people in our community. Is vaginal estrogen something they should be looking at?
The urinary symptoms can be increased frequency, urgency, urge incontinence, which is basically that like you're putting the key in your door to get home and you're like, oh crap, I gotta go. And you're like, sure,
Yeah.
I'm not at the toilet yet. And it's just like, too bad, your body's decided you're at the toilet. Also helps with that like peeing at night. It doesn't, we don't really have much evidence that it helps as much with stress incontinence, which is that like leaking with like laughing, coughing, sneezing, that type of stuff.
Okay.
And again, really good at helping to prevent urinary tract infections. So those are the bladder things that helps with. So vaginismus is basically when you've got some pelvic floor muscles that are really, really tight.
Yes.
And it can cause, pain as well as pain with penetration, like painful sex, painful gynecologic exams. So if you have some overlying skin conditions, again, with like low estrogen, with menopause, birth control pills, breastfeeding, in that case, yes, the estrogen is helpful, because if I've got a muscle here, she's clenched, because she's all nervous and all tense, and then I've got skin overlining that muscle that is inflamed and on fire. I don't care how much work you do on this muscle, the skin is still tender. This muscle's like, I'm not releasing. Things aren't safe. She still hurts. So when you add in the estrogen and this skin feels better, your muscle's more apt to be like, all right, I'm going to listen now and listen to the exercises and the dilators and the wands and do all the things I'm supposed to do. If there's no skin issue, don't really have evidence that adding in the estrogen itself would make a big difference as far as the muscles go.
Okay. Great. You heard it here first. All right. One other one that we had, kind of going back to breast cancer, I think risk and the worries there. What do you do if your doctor has said that you're estrogen dominant? How does that play into HRT? Yeah, we'll do that one first. There's one
Estrogen
more.
dominant isn't, the word estrogen dominance isn't even really like a medical term. And so I'm kind of nitpicky when people use it. Like, why are we using that? I guess if we're talking about like estrogen dominant types of states, like sometimes patients with PCOS can have higher levels of estrogen, less progesterone in their bodies. This doesn't mean that you're not a candidate for hormone therapy. You won't need it, all the things. Maybe you won't need estrogen replacement until like as you get much closer to menopause. But at some point, I don't care how much estrogen you make, it's going to drop off. One day your ovaries say, we're done. We're going to go to Florida and retire. And when they
Right.
do, they're not going to be making that estrogen anymore.
Okay. What about if I've had breast cancer? Am I not a candidate for systemic HRT?
Then this is a topic that we are continually learning more and more about. So at least at this point at Intimate Rose, you're not a candidate for systemic hormone therapy. Vaginal estrogen, absolutely, all day long. And this is where it gets confusing, because I know we're like, oh, estrogen doesn't cause breast cancer. And it's like, well, why can't I have it if I've had breast cancer? The reason being, depending on the type of tumor, if it was estrogen receptor positive, basically, we're afraid that if we give you estrogen, it will kind of like promote more tumor growth. So it's not going to cause something in the first place. It doesn't have the power to cause a cancer to appear. but it can have the potential if there's an existing cancer to kind of help it to proliferate, which we don't want. There's definitely more research going into this and more nuance and all those things. So it's really complicated. Oncology is not a simple subject, and everyone's cancer is very different. So it's hard to kind of make blanket statements for everybody.
I feel like it's like that with hormone stuff in general. I'm like,
I know.
everybody's so nuanced and everybody needs a little bit of a different thing. But that's why it's important to find a provider that understands all of these different nuances, up to speed on the latest research, you know, and that you're comfortable with kind of walking this journey with them, because it isn't going to be black and white. So you want to make sure you find somebody that can navigate with you, which we're hoping at Intimate Rose we're going to do. I know we're getting close to wrapping up, and I know there were still a few more questions that we didn't get to. Andrea and I have already discussed this, and we will try to get back to you guys in some way to kind of answer anything that we didn't get to. And I think we might want to have more of these. If y'all feel it's not good and effective and you want to have more of these things where maybe we can get into more nuanced topics, that would be kind of fun. Since I know this was a little more high level. So just want to make sure all of you guys know that Intimate Rose does offer a lot of the options that we talked about today. You can go to intimaterose.com/menopause, and that'll take you to an overview of what all we have. We definitely have systemic estradiol. Ooh, we did not talk about that, estrogen and estradiol, but we'll circle back to that. But we do have the systemic options. We have vaginal estrogen. We have even non-hormonal options, which we also didn't get too much. But you know, if you do have symptoms and you are not a candidate for traditional HRT, then we may be able to help you out with some non-hormonal options that are still prescription, that can offset kind of those more traditional symptoms. Andrea, is what I always think of, like hot flashes, brain fog, irritability, that kind of thing. But please go. The assessment is free, so you can go in there. You can fill out some information about your medical history and your symptoms, and you'll be able to get a preview of kind of like what your treatment plan could look like based on what you qualified for. And then if you want to move forward and have that discussion with a medical provider, you can submit your form. We do take credit card, but nothing is actually charged until you've had that meeting and you have a treatment plan in place. And then you would be charged, and your prescriptions would show up right at your door, which is also really nice. You don't have to go anywhere. But Andrea has a code. Andrea has a code today. So tell them what your code is, you know.
Very fancy. My code is Andrea 100. I will take
Andrea 100.
So that there it is.
Go ahead.
That'll get you, and correct me if I'm phrasing this wrong, but it gets you $100 off of like a 3 months of treatment. 3 months package.
Yes. So it's a pretty good deal because you actually save when you do 3 months anyway, and you can go ahead and get $100 off your plan. So we'd love to have you guys check everything out. I'm Melissa at intimaterose.com. Like, you can email me personally. I'm happy to answer any questions. We'll also have different ways to get this recording out to you guys so that you can share it with your friends, share the news, spread the word. And but feel free to reach out to us. We have an awesome team. They can jump on a call with you and walk you through anything specific you may need to know. And hopefully these were helpful. I learned something. I learned things, Andrea. Thank you.
I'm glad. I hope, I hope we answered your questions. Like Melissa said, we couldn't get to everything. So tell us what else you want to know. If you would like to have another one of these, we're happy to do it and answer all the questions.
Yes. And we get to hang out, which is fun.
Yeah.
But we might have to bring Panoli and Bob, the dog.
Yes.
The dogs are always fun.
Mine's unconscious, so she wouldn't offer much to the conversation currently.
Mine is too. He's all curled up. He's enjoyed it immensely. I can tell.
Yes, he learned a lot.
Yes. All right, girl. Thank you so much for doing this, and thank y'all for joining us. And hopefully, we'll tune back in soon.
Someone noticed my cross stitch. Thank you, my Live Laugh Lube cross stitch. I appreciate you for noticing.
Have they all seen your wallpaper? I think her wallpaper is pretty special too.
It can be subtle, but they're all clitorises.
We should do like a like one of those games at the end where it's like, who was paying attention?
I know.
We like ask questions. Yeah, they like the wallpaper and they picked up on it, which I'm impressed.
Good job, Heather and Liz. Good eyes.
Yes. Oh, yay. They say it was a helpful session, Andrea. I'm glad.
Yay, I'm glad. I'm really, really glad.
Yes. All
All
right.
right.
Well,
Be
I'll
free.
see you on the other
On the other
I'll see you
side.
soon. Okay.
Goodbye, everyone.
Bye-bye.